Hi, good morning, good afternoon, and good evening. Welcome to our annual Pain Center Conference, Advancing Pediatric Pain Care Equity, Addressing Challenges and Opportunities in Low and Middle Income Countries. My name is Fiona Campbell. I am co-director of the Sick Kids Pain Center, and I'll be your moderator for this session entitled, Is Asia Ready for ChildKind? And it is my very great pleasure to introduce Dr. Angela Yeo, a senior consultant pediatric anesthetist at KK Women's and Children's Hospital in Singapore, where she is the clinical director of its children's pain services. A trailblazer in the region, she established Asia's first interdisciplinary pediatric chronic pain clinic and led KKH to become the first hospital in Asia to achieve ChildKind international certification in 2022. She's deeply committed to advancing pediatric pain care in Southeast Asia. She's championed education, research, and advocacy through her leadership as the founding president of the Pediatric Pain Special Interest Group of the Asian Society of Pediatric Anesthesiologists and as founder of the Association of Southeast Asian Pain Societies Pediatric Pain Network. Angela currently serves as a counselor with the Pain and Childhood Special Interest Group of the International Association for the Study of Pain, or IASP. Over to you.
Good morning, good afternoon, and good evening, ladies and gentlemen. My name is Angela. I'm a pediatric pain physician and the clinical director of the Children's Pain Service in KK Women's and Children's Hospital, Singapore. KKH is one of the first and only sites outside of the USA and Canada to receive ChildKind certification. So I'm very honored and excited to be able to share our experience with you as invited by my lovely good friend, Dr. Anuradha Sudhir. Before I go into my main talk proper, I'd just like to say I have no conflict of interest to declare. And so the next 30 to 45 minutes, I'd just like to introduce ChildKind to everybody in the audience who isn't aware of what it is. I'd also like to talk about the 5 ChildKind principles, which guide how the certification process is carried out, and then introduce just, some of the little logistics behind the certification process. But the meat of my presentation today really will be about how we did it in KKH Singapore, and I'm going to use that as a case study. And then I'd like to share a few of the ASEAN perspectives when I polled some of my colleagues in the Southeast Asian region. So what is ChildKind International? Now, ChildKind International in itself is a nonprofit organization, and its mission really is to improve the quality of pediatric pain care throughout the world. And how they do this is by supporting and recognizing institutions that have developed these best practices. And it actually encourages open exchange of these best practices and protocols through their open resource library, and they build connections amongst clinicians by providing ongoing educational forums. So the dream of ChildKind actually first came about in about 2005, 2006. And back then, what had happened was its founding members asked for the Pain in Childhood SIG of the International Association of the Study of Pain to endorse the concept of ChildKind. And having received the endorsement, 2 years later, an organizing meeting was held in Bellagio, Italy in 2008. And that was with the support of the Mayday Fund, the Institute of International Education, and the Rockefeller Foundation. So there were about 20 or so representatives of 14 different countries, as well as the WHO and the Baby Friendly Initiative, who had attended that meeting. And that same meeting was where the basic criteria, or the 5 principles, as they have become known, were established. So 2 years after that, in the Pediatric Pain newsletter of the Pain in Childhood Special Interest Group, a commentary was written by its founding members, notably Professor Neil Schechter, as well as Professor Adam William. So these are the 5 principles of ChildKind, which are also kind of referred to as the Bellagio Declaration. And in essence, These are what they each stand for. The principle number one, that there is a facility-wide evidence-informed written policy on pain assessment, prevention, as well as management. Principle two, that there are comprehensive and ongoing education and awareness programs, not just for staff, but also for students and trainees, patients, as well as caregivers. Principle three talks about how all children have pain assessed using an evidence-informed, developmentally appropriate process, and that it is documented in the patient record. Principle four looks for specific evidence-informed protocols for pain prevention and management, including pharmacological, psychological, as well as physical methods. And the final principle looks at regular institutional self-monitoring, which should review protocols, policies, as well as patient outcomes with feedback to staff within a framework of continuous quality. So the process behind it is quite straightforward, really. There's a pre-application phase where when a hospital who is interested expresses their initial interest, what will happen then is the site fills a gap analysis form and then have an assessment interview with the ChildKind certification committee member. And after having gone through that, the committee member either recommends that they fill the gaps and then come back, or to proceed on to a full application. So the full application then requires a portfolio to be filled. And so that is then reviewed by the ChildKind certification committee per se, and any readiness to proceed is then determined. And we're talking now about proceeding on to a site visit. In general, what has happened in the USA and Canada, to my knowledge and my understanding, is that it's usually a one-day site visit conducted by the certifying team. And what that does is incorporates the portfolio review and meeting with site leadership. And at the end of that day, what happens is that the results of the site visit are then reviewed by the committee. A report is provided, recommendations are provided in that report, and certification is given if the criteria are met. So that's fairly straightforward. To learn more, do contact this lovely, lovely Meredith Trout, who is the program director at ChildKind International, and she will really sort you out that way. So as mentioned, Kiki is actually one of the only hospitals outside the USA and Canada that has been certified as a ChildKind hospital. And here we are, this tiny little red dot on the right-hand side of the screen. And we are actually geographically located to influence other Asian partners in the region. So I'm going to talk a little bit about our ChildKind experience as a hospital, being part of the team that was responsible for bringing it to fruition. This is me with my children's pain management clinic team and one of our patients who was kind enough to testify to the good work that we do in our hospital. So this happened for us back in 2022. We had actually initiated it probably in 2021. But as everybody will remember, we were still kind of in the throes of COVID, which had pretty much hit us fiercely in 2020. So with all that lockdown and everything happened, we were only closer to being ready at the end of 2021 and 2022. It was meant to be a site visit with 3 committee members flying in from Canada and or America. However, there was a little bit of a hiccup, and I think our members, they kind of came down with COVID. So in the end, the whole visit was done virtually. So We then had to extend it instead of a single day site visit. Of course, we then had to hold it over 3 days in 2 different time zones, which was really challenging for everybody involved, but we made it through. And it was a massive project. This is like a mammoth project. It involved more than 42 individuals and teams from more than 20 disciplines. And there were people from all over the hospital chipping in. You can see the different groups that were all involved in being part of this certification process. In addition to the manpower, we also need people to produce videos. So they had video tours of areas in the hospital. We had moving tech support. We had people with iPads running up and down the hospitals to show our certifiers the various sites and to have interviews with people through the iPads. So we brought them to the neonatal ICU, the children's ICU, the oncology ward, the dental center, plaster services, cleft and craniofacial center, the pain management clinic, the outpatient clinics, and the children's emergency. We pretty much went everywhere and showed them almost every last square inch of the hospital in this virtual accreditation certification process. And that was very interesting. So how did we do it? So basically what we put together was by principle. So to give enough evidence for principle one, which is really looking at institutional commitment, our program kicked off really with a meeting of the committee with the senior leadership, with our pain committee and with our pain link network, which is actually a group of it's a nursing pain network throughout the hospital. Principle 2 looks at education, and we had presentations in by various medical and surgical disciplines. And we talked about pain education, not just for healthcare staff and clinicians, but we talked about pain education for the new staff, for the trainees, for the rotating doctors. We talked about ongoing training and refresher learning for the nurses as well. We talked about pain education in allied health providers. We also talked about for pain education and ancillary staff, like our clerks, for example, our security staff. And we talked about pain education for patients and parents in the inpatient setting, in the outpatient setting, and also to the public through some of our activities like Pain Awareness Week. When we talked about principle 3 to give them evidence of it, we basically took them through to various areas and gave them examples of how we did it differently in the different age groups. So they were in the neonatal ICUs and looking at the pain assessments there, the musculoskeletal clinic and the children's pain management clinic, which does both acute pain, procedural pain, as well as chronic pain. We went through several case studies of recurrent abdominal pain or oncology palliative sort of pain, and we took them to children's emergency as well. And to bolster principle 4, we had presentations by our surgeons, our burns nurses, our acute pain nurse, what nurses on the wards were involved in nursing assessment. We also had our child life therapy, our child life therapist and her team, which also comprises of a music therapist and an art therapist, and they came to speak about using non-pharmacological ways of managing pain in the acute pain setting, procedural pain setting, as well as in the chronic pain setting. We also introduced some of our procedural pain initiatives that we had in place, and we organized for patient and parent interviews. Principle 5 looks at continuous self-improvement. So our Office of Patient Experience and our audit teams took them through our hospital feedback forms and how we use that to change our practice and address pain requirements within the hospital, as well as a benchmark for us to measure our own performance against. We had also presented our opioid safety and stewardship projects, our reporting system on analgesic gaps, and our nursing audit databases. And then this kind of came to the end after the second day. They had a bit of time to regroup, consolidate everything that they heard, and then they had closing remarks on the third day where they gave us feedback and recommendations. But pretty much, they were pretty much happy with what they had heard. And so that is evidenced here. by the many, many smiling faces. Here you'll see Professor Alan Finley, Gary Walco, Bonnie Stevens, and Neil Schechter, and a very happy KKH team. So it was a very successful exercise. So some of our standout features really are the multidisciplinary hospital pain committee that we have that looks at pain in different disciplines. We have a pain network, which is a network of nurses throughout the hospital uh, who continue to update the nurses on the wards. As with regards to pain education, we do have regular pain education and training, pain protocols in most clinical areas, including protocols for procedural pain. We have a very strong child life presence and advocacy for non-pharmacological pain therapies. And we have the Children's Pain Management Clinic, which is Asia's only interdisciplinary pain management clinic for children. We also have Pain Awareness Week, which I'll show you a little bit more about later. And we pay a significant amount of attention to quality improvement throughout the hospital. So we found that some of the benefits of working towards this certification was really that it gave us a structured direction and purpose in order to improve pediatric pain management. So we knew we were doing a good job. We just needed kind of like a checklist to a list of like check boxes to tick off. And organizing it in principles as such really helped us structure it in that way. And because we undertook this and it required so many hands on deck, it really increased staff awareness, involvement, and participation. And it forced us to collate our hospital-wide resources and put them all into one database. Or one folder so that we could see where our deficits were and we could address those deficits to the benefit of our patients. And so after we had achieved certification, it was really, it was great. It was great publicity for the hospital. It did definitely increase public awareness of our hospital's standards and commitment to good pain management. But another positive side effect of it, of course, was that there was then increased public awareness of, sort of more obscure conditions like pediatric chronic pain, for example. What I found was very encouraging really was that it also resulted in sort of a semi-permanent, I feel, because it's still ongoing, institutional culture shift. So there's actually still a lot of attention paid to doing a good job of pain management, and the continuing support from hospital leadership has been excellent, and that includes financial support for some of our activities. And so this is the Pain Awareness Week that I was telling you about. So every September, we have 1 week in which we have activities and public education with regards to various components in pain awareness. So we have invited the doctors in, as you can see. So that's pet therapy. We have artwork. So we need supplies and kind of put up a whole exhibition for patients to explore their own concept of what pain does to them, how it is not just a physical thing, but also an emotional and psychological. So this is how we kind of bring them to the awareness that pain is not just biomedical, it's also psychological and sociological in that sense. And we also have costumed actors come and play the kids in that week. So it's great fun. That week is always a whirlwind of activity. The kids are usually really happy. And at the end of the week, we actually do have the Pain Champion Awards that we send out. And so sometimes we award a whole team. Sometimes we award individuals. These are just various categories. And it's really nice that the hospital continues to reward, good pain practices. It really encourages people to keep doing the good job that they're doing. So my next part of the talk really talks about the landscape in Asia. And so it was a commentary that we had written in response to Christopher Eccleston's article that talked about how developed countries could improve pediatric pain management through four transformative goals: making pain matter, understood, visible, and better. So the current incumbent president of the International Association of the Study of Pain, the lovely Mary Cardosa, who is my good friend and well-respected mentor, invited me and Siok to contribute to this commentary. And in essence, what we talked about was in this answer to Eccleston's article was that in Asia, it was quite obvious that we had competing priorities and quite fierce competing priorities with other disease states. So, for example, malnutrition, infectious disease, and that knowledge gaps in health administrators and clinicians and the public really kind of played a huge role in that because that dictated institutional policy and attitudes towards pain management. In addition, in Asia, there is actually this really strong cultural, religious kind of acceptance of pain and suffering and praise for stoicism. So it can be a bit difficult. There's also great acceptance of traditional alternative medicines, and that can actually delay pursuit of treatment in this population. And that's not just it, because even when you want specialized pain services, even for adults, it's not available. So that becomes very difficult. If they are available, they tend to only be available in major cities. And so you've seen Asia, right? There's a few major cities and huge, far-flung rural areas. And it is difficult for people to get the health care that they need. So medications and therapy services for children are usually unavailable or inaccessible. And of course, this is a worldwide problem. There is a lack of pharmacological safety studies and evidence in children. So I'm active in the federation, one of the federations of the IASP, and this is the Association of Southeast Asian Pain Societies. Now, this particular federation has a pediatric pain interest group, and that's the Pediatric Pain Network. And we come from many, many countries in the region in ASEAN. So from Indonesia, Malaysia, Myanmar, Philippines, Thailand, Vietnam. And so I kind of reached out to my colleagues and I said, hey, I'm just going to take an informal poll. Have you guys heard of ChildKind, and what do you think of it? Well, I shared with them the website, and you know what? 100% of them believed that certification, ChildKind certification for their hospitals would have value. But when we looked at the requirements, the principles and country requirements, and I asked them, hey, so do you think your hospital is anywhere near ready? This is what they gave me. And so when you look at the reds, those are actually within the same country as other purples. So as you can see, various different sites, but even within the same country, are actually at various, kind of just at different points away from achieving their goal. And none of them actually are almost there. When I asked them, so which of these principles would you think you would have the most trouble with in your institution? Without a doubt, it was principle number 5. And so we talked about common barriers. I did have like an open free text kind of form, and I said, okay, tell me, what do you think are the 3 major barriers that you're facing in your institution? And these were some of the common themes that came out, repeatedly across all 12 of my respondees. So they talked about how there was lack of ministry and institutional support. They talked about lack of funding and resources, including manpower. They talked about lack of awareness and acceptance amongst colleagues even, or putting a multidisciplinary team together. They talked about lack of training or educational opportunities for themselves or for their teams. And they talked about establishing regular evaluation and QI, just not really being part of that culture at the moment. And they do struggle with simple things like access to medications. For example, EMLA is just not available in the country. So then we kind of threw out some solutions, and actually it kind of all boiled down to a few things. Three major things, in fact. So if you look at the possible solutions to a barrier that had grown up, it's really about one, making friends in the right places. Usually they're the high places, but sometimes it's just the right places. It's about being able to tell a good story, whether it's by tugging on the heartstrings because you have a patient who's willing to give a good testimonial or give a good video testimonial, or whether it's you have good data to back up um, the information that you're sharing. And it's also important to find your tribe. So this is a phrase that I use because it has never failed to amaze me um, when I ask around and discover, and discover is probably the right word, I discover people who actually are passionate about the same thing. Sometimes they're not passionate about the exact same things. Passionate about they're passionate about certain components to it. But definitely, if you find people who are passionate about the same things that you're passionate with, are passionate about in your hospital, you actually have a tribe. And this is where you also receive support and validation of your efforts to do the right things by the kids that you're treating. So we shared amongst us some of the difficulties in making and sustaining the differences that we try to advocate for in pediatric pain in our hospitals. So I'm going to share with you guys some of the lessons that we learned in KK when we tried to introduce what is now known as the comfort promise. So the comfort promise looks at a few components. It looks at procedural pain management through using topical analgesics, through parental presence, through comfort holds, through distraction and education and similar means. So when we were embarking on our project way back in 2010, after I had come back from the Royal Children's Hospital in Melbourne, my boss and the Office of Patient Experience spoke to me and said, how can we do this better? We are getting patients, we are getting feedback, angry feedback from parents who say that their kids' pain is not being managed well. And they were specifically referring to IV cannulation and phlebotomy pain. So what we did, the three of us, was to initially sit down and assess what we already had. And with the knowledge that I had, I said, hey, you know what? We need to put on EMLA, right, on the children. That's a topical anesthetic. It's going to make them numb. And then it won't be so painful because that's what the parents are complaining about. And 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 then we realized, hey, actually, we already have EMLA. It's already in the hospital. They're already, there was already a protocol for prescribing it. It's just that we weren't using it. So that was like eye-opening. I'm like, oh, we already have it. So I didn't even have to champion for it. What I had to champion for was actually using it. So what we then did was we found a team that would help us do this. And the team that was important was the team that would use the EMLA. So the junior doctors on the floor, for example. And so if you don't, you need to find someone who is influential enough. So maybe one of the strong nurses on the ward or one of the registrars who's senior enough on the ward to kind of push for this difference. So finding that team made a huge difference. It helped us to establish and kind of spread the word, so to speak. But it was also important to have someone's ear, meaning that you want somebody who's important enough to put their foot down and say, no, it has to be done this way. And so it was important to find that particular someone. So that was the head of department for the peds medicine team. And so we kept it small at the beginning. We kept it to one ward, and then we eventually, and office hours, and then we eventually went to two wards and then office hours. And then we expanded it throughout the children's tower and kept it in office hours. And then we started doing it out of hours as well. So as you move along, you slowly scale up. And sometimes you just go for the low hanging fruit. So at that point in time, um, when you talk about process outcome versus, you know, what we did was we basically said, okay, everybody who needs an IV cannulation or a blood draw, we just smack on the EMLA and we're going to consider that a win. And so that was easy because then it was really just about applying the EMLA. We didn't care if they actually had pain or not. So that was funny in that way, but that worked because 10 years down the line, I have 100% success rate of people applying EMLA before IV cannulations or blood draws, as long as they're not emergency needle sticks. So that's fantastic, but it did take us 10 years. So I think the important thing is to work on making all these little differences and then slowly scaling it up. But also, when you make these differences and then you have these wins, right? Make a big noise about it, like celebrate it, validate, um, you know, kind of praise it because people like to know that that little effort that they made actually did make a difference. And you're gonna hit the wall sometimes and you're gonna get rejection and your numbers might drop again and it just doesn't look like it's taken off and in any big way. But it's important to just keep swimming. With Finding Nemo and that Dory, yeah, you just keep swimming, even if the whole ocean seems to be against you. Don't get disheartened. It's helpful to have your tribe, like I said, to find your tribe because when you are feeling down and you feel like, you know what, I haven't made any difference, these are the people who are going to back you up and say, you know what, let's see if we can do it another way. You're still doing a good job. All right, so it's important to still have that support system in place. When you have made a bit of a difference, sustaining it is always a bit of a challenge. So what I found work in our setting really is about giving regular feedback. So we used to give the nursing sisters in each ward a report at the end of each month. And so when you have regular assessments or regular audits or whatever it is, giving that feedback back to the people who are in charge of that ward um, tells them whether or not they're doing a good job. But it also encourages competition and kind of spurs them into doing a good job as well. So you could tell nursing sister, and you could just give her a report that says, your average is 50% of your kids had EMLA applied, but the best is 87%. So that then spurs her into achieving, a better percentage of children who's had EMLA applied. So that's one of the ways you can use, the normal competitive human behavior to evoke a positive change. The other thing about good behavior is don't fail to reward it. As I mentioned, people do like it when they are singled out for good behavior and it encourages further good behavior. So I would say if it's noticed, reward it, validate the effort that went into it and have a bit of a show and tell, We, at the end, or what, halfway through or three-quarters way through this, what we did was we then said, hey, we gave an update to the senior leadership and said, okay, so now we have 80%. And in the whole spirit of QI, we said when we started, we had 50% of our patients, or actually we had probably about 34% of our patients who had EMLA applied before their blood sticks. And by the time we got three-quarter of the way through, we were hitting 70%. And so we kind of had, charts, to show the people who are higher up and to whom it made a difference. So you can show that you're making progress. And they were quite pleased with that. So then they kept, kind of supporting it, which was great. But again, it is possible to just keep like hitting a wall. So don't be disheartened, just keep swimming, all right, and find your tribe. So um, I am happy to take any questions. Please email me. Feel free to reach out. I am a proud member of the Asian Society of Pediatric Anesthesiologists, where we have a pediatric pain special interest group. I'm also a counselor on the pain and childhood special interest group of the IASP. And I'm happy to help you find your tribe. So yeah, feel free to reach out. And before I go, I do want to share with you the IASP 2026 World Congress on Pain is coming. It's going to be held in Bangkok, Thailand from the 26th to the 30th of October. I know it's a bit far from Canada, but for everybody in Asia, if you're interested in finding your tribe, I think you'll find some of us there. So, looking forward to see all of you and have a good rest of conference. Thank you.
Well, thank you, Angela. That is incredible work. Congratulations on achieving ChildKind. Having been involved with the same process, I know how much work this was involved for you and for your team. We will open the floor for questions. I'm sure there'll be some about ChildKind for you. I'll just have a look in the chat and see if, please put questions in the chat or put your hand up. You know, I realize that Singapore is now a high income country. But that you are geographically close to low and middle income settings, particularly in Asia. So you articulated the barriers very well and solutions, which, by the way, would be very relevant for other high income countries as well. I looked at them all and recognized them myself. So, what do you think some of the most low hanging fruit might be for people kind of joining from low and middle income countries? You know, you had Emma in the hospital, they may not. Like, what can they look around for and grab onto just to kind of get started?
Right. Okay. So there are lots of it really depends on where you identify your major issues and where you really want to get started. It also depends on who you are in the hospital. So I was quite blessed because I came back from fellowship and I was given a task for people who are struggling to kind of even make an impression, higher up in the hospital who need to kind of get the attention for permission to do things, then sometimes I feel like um uh maybe just getting the stories out first would be a good thing because we're always in contact with patients, most of us, right? And having patients share their stories, I feel like emotional heartstring tugging stories um carry across quite well um, for public sympathy votes. And so just having that collection in your phone and saying to a patient, would you mind sharing if somebody higher up in the hospital could make a difference? Would you mind sharing your story? And sometimes they're willing to do that, to be heard. Um, and I think the other thing that really speaks when you don't listen to heartstring stories is data. So sometimes simple things like just a sort of award sweep and saying, "Hey, what was your pain in the last 24 hours?" And this kind of harkens back to something that Stefan Friedrichsdorf had done previously at Minnesota as well, which he shared in his pediatric pain masterclass previously. And that was, you basically have an on the ground audit, ask kids in the past 24 hours, what was your worst pain and what was it due to? And that kind of then gives you data to say, hey, actually, this is what we're seeing. And and then you can kind of leave it hanging. Like, what are your solutions to this? So obviously you're kind of trying to build that story, but I think giving people the motivation to do something about it is probably the first step. And these are just some of the easy things you can do, but it can be quite resource intensive. And I think a lot of us, so amongst my peers in Asia for sure, and I know a lot of people, not in Asia, even in all, in America and Australia and Canada. Actually, a lot of us are very passionate about the work we do, and we actually work beyond hours. We kind of put ourselves out there, and we just kind of throw ourselves into a lot of things because this is what we believe in. So if you're one of those people, you do have to kind of put yourself out there in terms of time and effort as well, and just gather that information first to make that impact. Because people knowing that it needs to be different is probably easy, low-hanging fruit. The other thing that is probably possible, I think, in a lot of areas, is getting training. Now that sounds a little bit strange, but what happens is there are actually very a lot of free resources, free online resources for pediatric pain training that is available out there. Like ChildKind has an amazing website, right? So the ChildKids curriculum is fantastic, and this is all free. So kind of getting people to know about it and then sharing that information and saying, hey, we can have a chat about this. What do you think of this module? I think that helps, and it's easy. It's lower hanging fruit.
Yes, I loved what you said about patient stories and data. And I think really trying to get that into the hands of the executives in the hospital. Sometimes people are a little bit scared of that, but if they have data that shows poor satisfaction with pain, they care about that, and they care about, sort of satisfaction with care in the hospital. Yeah, those are really important points. Have you used the ChildKind resource library at all?
Yeah, we have. We've contributed a few things to it. So what I've realized about the online resource library, though, is that you do have to kind of keep an eye on when it was last uploaded, like when that protocol or whatever it is you're looking at was last uploaded, and you kind of just have to make sure that you're working with the latest version sometimes. But it's great. There's like a lot of stuff in there that's incredibly useful. And it's amazing how ready people are to share. I I think that's really fantastic. Yeah.
I think people really do want to help. Well, that was just a fantastic presentation overview, and I know that Angela would be happy to be contacted if you have any questions for her. Thank you so much, Angela. It was
Thank you,
terrific.
Fiona.
Yeah, thank you. Good to see you.
Thanks for inviting me.